So what I'd like to do with you in the remaining presenting time before our panel is to go over some concepts in large vessel vasculitis, but particularly giant cell arteritis of the elderly and Takayasu's. And I'll share with you some thoughts about Gca initially and then Takayasu's. And then I'm going to try and make a case. I can't prove it, but I'll try and make a case that these diseases that we consider distinct might actually be more similar and perhaps even the same disease occurring in two different age groups, and the phenotype of the disease being skewed by immunologic senescence, perhaps, and perhaps the changes that occur in the course of tissue aging, structural, antigenic, and numerous other changes. So let's start with GCA. So I think everybody here probably recognizes the clinical characteristics of GCA. I'll share these characteristics in the context of those large clinical studies that have had at least 100 patients or more enrolled. So the range that I show you of characteristics here, I think is representative because of the large numbers of patients with well-described clinical characteristics in each study. So a lot of people who haven't looked at this data, I think of GCA as the disease that has a lot of systemic characteristics, when in fact it's only 20 to 50% of patients who present with fever and other constitutional symptoms. So not everybody with GCA has systemic characteristics. Almost everybody presents with atypical headaches, even though the range in large studies is from 60 to 90. Atypical, uncharacteristic headaches, perhaps with pain in the scalp or temporal artery, is the most common feature. And about 30 to 50% of these patients will have characteristics of PMR, achy shoulder girdle, more often usually than hip girdle, pain, stiffness, but it's only 30 to 50%. The acute visual abnormalities, to give you this figure that ranges in different series from 12 to 40%, I've excluded the large series that come from ophthalmologists because those series are biased towards people who are referred with GCA with visual abnormalities. So almost all ophthalmologists have within their cohort an overwhelming percent of people with visual impairment or amaurosis. So when you then look at other features that we consider pretty characteristic of GCA, jaw claudication, that's actually masseter muscle ischemia because of involvement of extracranial vessels that supply the masseter muscles and muscles of chewing. It's really has nothing to do with the jaw. It has to do with masseter muscle symptoms with chewing. And the extremities, claudication in the extremities, 5 to 15%, would lead you to believe that this is a disease that does not frequently involve large vessels. But that's just the range of involvement based upon clinical symptoms. And it's clearly an underestimate, and I'll show you why. The most specific feature is a temporal artery biopsy, which is positive in 50 to 80%. Again, if you look at ophthalmology series, it's usually around 80%. If you look at rheumatology, internal medicine, neurology series, it's closer to 50 to 60%. And of course, dramatic response to glucocorticoids. That should occur in 100%. Even if you have a positive biopsy and you don't have a dramatic response to corticosteroids, you should begin to question the diagnosis. Because some of those people, as rare as it might be, might even have a paraneoplastic disease that involves large arteries, including inflammation of those arteries. So we understand the clinical phenotype in terms of describing it, and we understand what the biopsy looks like and what the inflammatory process consists of, right down to immunophenotyping of the cells and the inflammatory infiltrate of this temporal artery biopsy. We know what the cytokines look like within this biopsy, and we'll talk more about that later. I'd like to focus your attention to support my thesis about large vessel involvement and how different or the same are giant cell arteritis and Takayasu's with this clinical study. This is from the Mayo Clinic. Neuninghoff, when he was there working with Gene Hunter and others, looked at 168 patients with GCA over a period of 50 years. And this was a retrospective chart review, so it wasn't a systematic evaluation of large vessel disease with all patients, for example, having imaging of large vessels. But what they found, based upon just what Mayo physicians may have done, in terms of the physical examination, perhaps occasionally imaging of patients with large vessel symptoms, was that they found that 27% of patients had clinically recognizable large vessel complications. And that would be particularly subclavian disease, less often lower extremity disease. And they also noted that 18% had aortic aneurysms, for which the risk of dissection could be as high as 50%. And when you look at those people who dissected, 9 had thoracic aortic aneurysm dissections and only 1 abdominal. This work has since been confirmed by numerous other people in terms of the frequency of aortic involvement in GCA. And the clinical estimates, again, retrospective surveys, 1 prospective study, is as high as 24% aortic aneurysm involvement. So this is one of my 80-plus-year-old patients' angiograms where you can see 2 stenotic lesions within the left axillary artery, and she has a matching one on the right side. She did not present with systemic constitutional symptoms. She presented with upper extremity claudication, headache, and a high sedimentation rate. So when we look at that Mayo series, the Mayo Clinic series, in terms of survival, there was no difference in survival if you looked at the entire population of their GCA patients compared to a control population in the Mayo environs. And if you looked at the patients, however, who had aneurysms, their mortality was markedly reduced. That is, those with aortic aneurysms. So there's no question that GCA can be a fatal disease. It's not just that elderly people have GCA and if they die of natural causes. No, GCA can kill. And it raises the question of how often should you screen for large vessel involvement in GCA if you have such a patient. And my argument for screening everybody does not come from the data that I showed you, because that data is principally from retrospective series, and I don't think it's adequate. What you really need to know about is a very old study that was done in 1972 by a pathologist named Gurel Osberg, and this was published, it should have been more widely distributed, in Acta Medica Scandinavia. It's a critically important study. It's a fairly pedestrian study. It's not the kind of study that would be funded, for example, by the NIH. But what Dr. Osberg did was postmortems on 14 patients with large vessel vasculitis. 13 out of 14 had GCA, 1 had Takayasu's. And the question that she asked was, what is the extent of large vessel involvement in GCA? not just what people come in with in terms of complaining about claudication, but what do you actually find at postmortem? And what she did is to remove the entire aorta and its branch vessels down to the elbows, down to the knees. So you say, okay, I could do that. That's just a very meticulous dissection. What's so scientific about that? But the remarkable thing that she did about that, beyond that dissection, is she took histologic sections every 2 centimeters along the way of that entire vascular tree. Now we're talking about a real laborious study, even though it's only 14 patients. But what she found from that is far more than what you could derive from a clinical study looking at signs and symptoms in living patients. And the findings are summarized in these diagrams, with the dark lines of emphasis indicating where she found inflammatory changes within the aorta and its branch vessels. And then note, in addition, there are these hash marks here, these angular lines that indicate areas of stenosis or aneurysm, but some morphologic change in the vessel as well. So there are people in this study who did not have any changes within the vessels in terms of a change in caliber, but where there were considerable changes in terms of inflammation found histologically. And when you look at all of this, you could see 100% of people with GCA had subclavian or innominate disease. 93% had carotid disease. 85% had aortic disease. GCA, when you look at it from an inflammatory perspective and histology, not just whether things are narrow or wide, you begin to get the picture that, doesn't this look just like Takayasu's? The other interesting thing about this finding, although it lacks in details because it's a study written by a pathologist, is she did report the corticosteroid therapy that these people received, which varied from months to up to 7 years in 10 cases. In spite of corticosteroid therapy, every single patient had active disease at the time of death. Now, we used to say when I was a trainee that this was a disease that burned out over time. There was an argument in the early literature that it burned out in 6 months. And then some people said, no, that's an artifact of short follow-up. Maybe it burns out in 2 years. And now most of us who have taken care of these patients over a long period of time have some doubt that it ever burns out in almost all people, or that most people with GCA can ever be taken off corticosteroids without having a relapse sometime later. So not the most sophisticated data, but very unique data that I don't think you'll see replicated anytime soon. So all cases, vasculitis at the time of death. 13 out of 14 deaths were in part cardiovascular. And why won't we replicate this data? Because in our hospitals, the percent of people who die in hospital have postmortems about 5, at the most 10% of the time. When I was a resident, it was a point of honor if somebody died on your service to try to get a postmortem. And how did you do that? Because you honestly explained to the family that you were not flawless, that you were puzzled by the cause of death and the course of illness in their loved one, and that hopefully you would learn a great deal in the postmortem that would help other people. That isn't stretching the truth, but nowadays we don't do that. We don't try for postmortems. Pathologists aren't keen to do them. There's no reimbursement for them, and that's why the Gorell-Osberg study won't be replicated. And that's a tragedy of our times. So with that data in mind, I'd want you to go back now and rethink, who do you screen for large vessel disease who has GCA? And I would insist that that should be everyone. And how do you screen it? The simplest way to screen is just look for signs and symptoms that would suggest ischemia and claudication. And because the average person with GCA in most reported series is 74, don't assume that claudication equals atherosclerosis in these people. It may in part be atherosclerosis, but it may also be their GCA, especially if it came on subacutely or acutely. So we can ask the questions, we can examine for bruits over all large vessels, and we can take blood pressures in all four extremities and compare for symmetry. This is a little confounded by the fact that as we all get older, our vessels get stiffer, so leg pressures tend to be disproportionately higher than arm pressures. But I still think it's worth doing, and I would submit to you that most, maybe everyone in the audience, except for the rheumatologists that are part of our consortium, does not do this. Because I know in practicing rheumatology for 12 years before I was at the National Institutes of Health and took care of people with large vessel vasculitis there, I didn't do it after 12 years of rheumatology, general rheumatology. And I could tell you when I got to the NIH for the Takayasu's cohort, it wasn't even done there in the prior 20 years of that program. Nobody had thought to do it. And it's obvious why you should do it. So I think that's the bare minimum of what you do. And then I think you look for any reason that you can, and I think I've given you enough reasons to do imaging. Certainly if you find a bruit, if you find abnormalities in asymmetry, and what should that imaging be? Well, my goodness, what happened there? Yeah. So I showed you this picture before. This is an invasive angiogram in my patient who has since passed away. So she had symptoms in her left arm. She had symptoms in her right arm. She had lesions that otherwise you'd say looked like Takayasu's, but she was 84 years old at the time. You could do that, but invasive angiography in an elderly person has some significant risk, and so we tend to shy away from that a little bit. We're more keen to get MRs. MRs are very nice because there's almost no risk in anyone with normal renal function who gets gadolinium, but with abnormal renal function, you do have to worry about fibrosing dermopathy. So with MR, we can look at black blood images, we can look at wall thickness, and we can look at the anatomy very effectively and do little harm. We could use PET. And in the beginning, when these reports first came out, and we looked at images like these that showed enhancement of the aorta and primary branch vessels in a study from Danny Blockmans in Belgium, and we saw reduction in uptake after a month and more reduction after 3 months of therapy, we thought this was going to become the gold standard. But not long after that, Carlos Alvarani reminded us that we really did need more data about sensitivity, specificity, prognostic implications about enhancement, and what was the effect on outcomes if you acted on a picture like that. And to this day, we still don't have that data, but Peter is overseeing a study that compares PET in register with CAT compared to MR. That's a very, very hard study to do. Maybe, Peter, during the discussion time, you can tell us something about how that study is progressing. But very important that we get to the point in these patients with large vessel vasculitis where we have imaging studies that actually also tell us something about inflammation. This may not be it, but it may be. So Gci outcomes, how do people do? Well, in the old days, before people carefully did prospective studies with very defined parameters of disease activity, everybody said they all did great. GCA was a great disease to have. Well, I'm here to tell you that isn't necessarily the case. This is data from 2 randomized controlled trials, one by Jover in Madrid, one that I was the PI on, and we looked carefully at relapse rates in patients who received steroids. In this study, there was another group that was compared steroids alone plus placebo versus steroids plus methotrexate. But the steroid-only groups had a high frequency of relapses within 12 to 24 months as we tried to taper steroids towards zero. And this is the hard data that tells you most people cannot come off steroids with GCA within at least the period over which that study was done. Now, there have been other analyses of adjunctive therapies to steroids, and I won't go into those, but I'll just give you my opinion. And my opinion is that none have shown unequivocal benefit that I think is clinically significant. But there is some new data that promises some new opportunities. And that data comes from Connie Wyand and Yor Garanzi. They generated this data while they were at Emory, and now they're at Stanford. And so what I'll point out to you in the studies of lymphocytes and cytokines that they did, and lymphocyte subsets, is if one looks at these Th17 pro-inflammatory T cells in patients who had GCA, no treatment versus controls, you can see Th17 cells were highly overrepresented. And if we look at Th1 cells, again, we can see in GCA patients had much higher numbers of Th1 cells as a percent of total CD4 cells. If you look at what happens with treatment, Th17 drops dramatically, almost to normal, and the Th1 cells, the number of Th1 cells, is essentially not affected by steroids at all. If you look at T regulatory cells, they're normal in patients with active GCA, and they remain normal after treatment. So Tregs are not significantly altered in GCA by treatment. And then if one looks at the product of Th17 cells, that's IL-17, with steroid therapy, it dramatically drops. And if one looks at what happens to the product of Th1 cells, gamma interferon, one of those products, it's not affected by steroid therapy at all. So steroids suppress Th17 and IL-17, but not Th1, and not one of the key cytokines of Th1 cells, gamma interferon, in the blood. Now, there are other cytokines that are related to Th17, IL-17, and these are Th17 promoting cytokines, IL-1, IL-6, IL-23. They're also suppressed, as is IL-17, but the Th1 related cytokines, as I said, were not, and one of the related cytokines to gamma interferon is IL-12. These represent very interesting new targets, potentially, for pharmaceutical development. Blockade of gamma interferon, for which there is not a safe product yet available, commercially available, but there is early studies with IL-12, and this is something that might be useful in GCA. And when you look at the immunohistochemistry from patients before corticosteroid treatment and after corticosteroid treatment, you can see IL-17 drops dramatically, but post-treatment you can still see, based on the brown staining, abundant gamma interferon. Now, Connie and Jorg have been telling this story for almost 20 years now that this data has evolved, and I think it's robust, and I think there's really something to it. So, do we have a useful adjunctive therapy to steroids at all in this day and age for GCA? The study by Nesher from Israel in 2004, retrospective analysis, okay, so with all the limitations of retrospective analyses, looking at aspirin, those patients who were taking aspirin versus those not taking aspirin. What was the frequency of ischemic events in these two patient populations without aspirin? 5 times less in patients who were taking aspirin and had GCA. We, again, realizing the limitations of retrospective analyses and all the biases therein, we did the same thing in our prior 143 patients over 5 years. And again, we saw a 3-fold decrease in ischemic events. There's been a recent study that's questioned the validity of these observations, but I don't think this is going to be resolved until we have a prospective randomized controlled trial. So now let's look at what we know about Takayasu's. Again, we know the inflammatory infiltrate. We know what it's made up of. We know how that inflammatory infiltrate affects large and medium-sized vessels. Here we see a large aortic aneurysm and a contiguous common carotid artery stenosis. And we know that these findings are mediated by a large profile of different cells, not neutrophils, but mostly mononuclear cells. And we thought for a long time the other cell that was excluded from this, in addition to neutrophils, which are scantily represented, were B cells. But now there is emerging data that points to B cells actually playing a role. So B cells are being found in these lesions, and it raises questions about the potential effectiveness of rituximab even in Takayasu's arteritis. And again, there's preliminary data that needs to be confirmed that shows that rituximab actually might be useful in Takayasu's. So we have a good sense of the clinical and pathogenic players. Of course, we, like with GCA, don't know etiology. So how do we do in treating these people? Well, we can almost put everybody into remission with super high doses of corticosteroids, just like we can with GCA. Some of these people are harder to treat, certainly, than our GCA patients, because as we taper the steroids, we find that patients with Takayasu's tend to relapse at higher doses of steroids than we see with GCA, where the average relapse occurs somewhere between 5 to 8 milligrams of prednisone a day. Here in Takayasu's, we see that happening in a far higher percent of people on higher doses of steroids. So most will go into remission, and most will relapse with tapering of steroids, and that includes those people who are treated with cytotoxic agents such as methotrexate, and we've published papers that suggest that methotrexate allows one to maintain remission with lower doses of steroids, but still most of those patients could not get off steroids even with methotrexate. So people say, well, why don't you come to our place and talk to us about difficult to treat Takayasu's? And what I tell them is they're all difficult to treat. There's no easy Takayasu's. So how do we do in terms of vascular interventions in these people? Well, because we don't control the disease as well as we'd like, 70% of the people within our Cleveland Clinic long-term follow-up cohort required vascular interventions. That's similar to our NIH experience where 50% required vascular interventions. And both angioplasty and vascular surgery were initially successful, initially within the first few weeks post-op in almost all of our patients. But followed long-term, recurrent stenoses occurred in almost 80% of our angioplasty patients and 36% of our bypass reconstruction patients. And you can say, well, that's just the limitations of technically doing these procedures. But I would submit to you that this is the limitation also provided by not controlling the disease adequately. Consider that these are young people, mostly women, and they've got hopefully a lot of years left to live. Their incidence of disability, partial or complete occupational disability, is terribly, terribly high. And when you look at it in terms of complete occupational disability, it's a quarter to half. Mortality, you'd say, well, that's not too bad. Even coming from a center where people are pretty well practiced. But these numbers take on a different meaning when you consider the mean age of presentation in both of these series was 26 and 27. So I find this somewhat daunting and humbling. We had published, Peter was part of this, a paper on anti-TNF therapy. It was principally infliximab in patients with Takayasu's that were difficult to treat. This is the lady who brought us to do that study. She presented with Crohn's and Takayasu's with features of both occurring within a month of each other, which led us to look more carefully at our prior NIH data as well as the literature, and led us to believe what is now commonly accepted, that Crohn's occurs more often in people with Takayasu's than by chance alone. And I think there's probably an important message there in terms of pathogenesis that we haven't gotten yet. But this is a complicated graph, but what I mean to point out here is the green indicating doses of prednisone. Each of these arrows indicates a relapse of disease over time. And so this lady came to us on already methotrexate plus steroids. That did not succeed in getting her steroids down below 20 milligrams a day. She was switched to Cellcept when there was an article in the Annals of Internal Medicine suggesting that Cellcept was useful. Well, it wasn't in her, and it hasn't been in any other patients we've used that in since. We then switched her to tacrolimus. That didn't do anything either. Here she wasn't able to get below 30 milligrams of prednisone a day. And ultimately, when we switched her to infliximab, her steroid requirements dropped dramatically. She had no features of active disease, and that continued to be the case for many years after that. We tried to take her off infliximab, and she relapsed as we tapered that dose. She refused steroids. She had gained 100 pounds on steroids, and we just put her back on infliximab, and she went into remission again. Subsequently, she wound up having what was present all along, a large aortic root aneurysm that had to have surgery because she had severe aortic regurg and was now developing heart failure. And so we were able to get the specimen from the aortic root. There were no signs of inflammation whatsoever. So we didn't do that post-mortem that Gorell Osberg did on her large vessel patients, but we're still feeling compelled to think that this might be real, that infliximab has a role in most patients here. We followed this series up some years later and reported our results in 2008. We had started with 28, quotes, resistant cases, most treated with infliximab, a few with etanercept, and mean follow-up at 28 months, maximum follow-up at 6.5 years. 60% were able to have steroid-free remissions that weren't possible before, that were now possible, and 28% were able to taper their steroids to less than 10 milligrams a day. Only 12% failed to get down to low-dose or no-dose prednisone. So we need a randomized controlled study of infliximab in this disease, perhaps another anti-TNF that is sorely needed. I can tell you, having tried, it's very hard to get funding for a study like this. I'll end with pointing out a couple of important things about taking care of these patients apart from what drug do I use and when do I use it. And that is the anatomic changes that you need to keep in mind as you take care of these people. So these people, much more so than the GCA patients, have striking anatomic changes that actually make the diagnosis. And when you consider the nature of the lesions, they're far, far, far more stenotic than aneurysmal. So out of all of the lesions in our NIH series, 98% of all lesions were stenotic lesions, and 27% were aneurysms. When we looked at the Cleveland Clinic series, we saw again something quite similar, 97%, 17%. And when you consider the subclavian artery, which is the most common vessel involved, subclavian vessels over 90%, and over 40% were bilateral. So where do you put your blood pressure cuff to have a sense of what are you really measuring? What are you really interested in? You want to know central aortic pressure, because it's central aortic hypertension that will determine morbidity in terms of cerebrovascular hypertensive disease, cardiovascular hypertensive disease, renovascular hypertensive disease, arteriosclerosis. You can't put the cuff around the aorta, so you use the arm as a surrogate. Well, in these people, the arm may not be a good surrogate. So maybe the leg. You need to know what is the best measure of central aortic pressure in taking care of these people. I will point out that in spite of having people who have occluded both subclavian arteries, I've never seen gangrene in these people, either in their arms or their legs. They're young people with an enormous capacity to develop collaterals. We had one person have a leg amputation as a complication of surgery because of numerous failed bypasses. So this person has no left subclavian, no right subclavian, and she presents with bilateral arm claudication, but her fingers are warm, her nail beds are pink, and this person presents with a dilatation of the brachiocephalic as it leads into the subclavian, but this is not going to alter blood pressure, but this will, this left subclavian. You need to know this to be able to know you can get a reliable surrogate measure of central aortic pressure in the right arm. But what if that patient, like that patient, also has abdominal aortic stenosis? Well, then maybe you don't have any extremity that will give you a reliable measure. And how did we find this out? Because at the NIH, we did not, when we did invasive angiography, when we didn't have MR yet, we did invasive angiography in everyone. And it wasn't until about 10 years into that series that we started measuring intravascular blood pressures. And in one lady whose blood pressures were 90/60, we ultimately found that her congestive heart failure probably was related to the fact that her aortic, central aortic pressure was 180/120. So you need to know, and in a patient like this, you need to put a catheter in. You need to know whether or not the post-stenotic blood pressure is the same as the pre-stenotic blood pressure. Is this hemodynamically significant? And when pressed, although it happens infrequently, you might find that in someone who is wickedly hypertensive with no surrogate extremity pressure to be measured, that you actually do have to do a bypass to be able to have a reliable measure. The other thing you're interested in doing these imaging studies is how many of these people have renal artery stenosis. In India, renal artery stenosis is the most common cause of hypertension in the pediatric age group. And 80% of people with Takayasus in India have one or the other renal artery stenotic, causing high renin hypertension. The numbers are less impressive in other countries, but are still nonetheless impressive, averaging 40 to 50% overall. You've got to know the anatomy. You need to know what it looks like in the extremities and whether or not the renal arteries are involved. So I won't belabor that point, but I think it's absolutely critical. You're going to take care of these people. You have to do more than give them the right drugs. You need to know where the lesions are and which ones are hemodynamically significant. So these diseases, Gca and Takayasu, to me over the years have begun to look too similar to ignore the differences. And to think that maybe they are really separate diseases, as most textbooks, including ours, which has a chapter on each, would lead you to believe. So we went ahead and we asked the question, if you have the same exact history, intake, physical form in all of your patients with large vessel vasculitis, and you're true to your protocol, you ask both the Gca and the Takayasu patients the very same questions. You do this very same physical exam. what might you find? Now, this was a retrospective analysis of that proposal, and it was based on the assumption that the separation of these diseases was perhaps artificial, a product of, historical bias and reporting, maybe. And so our analysis did use the same standardized tool. We did do vascular imaging as is required in all people with Takayasu's, and only in 62% of patients with GCA, which is a significant limitation of the study. We would have done it in all if we could have gotten insurance permission in all. But same standardized interview and examination. And what we observed was that both diseases shared the same symptoms and signs, vascular lesions, although in different frequencies. So these are the graphs that describe those findings. And the asterisks indicate not that one is present or absent, but that these are statistically significant differences. But you can see, even in this example here, new onset headache, very common in Takayasu's as it is in GCA, although much more common in GCA. Jaw claudication does occur in some people with Takayasu's, and so on down the line. So those are just signs and symptoms. When we asked people about their aches and pains in GCA, obviously we asked about what we would call PMR, but lo and behold, when we interpreted those symptoms the same as we would in GCA, in Takayasu's, we found 13% of our patients had PMR. Amaurosis. Remember, Takayasu was an ophthalmologist, and the lady that he reported was someone who had bilateral blindness. By the way, he wasn't the first person to report this disease, nor did he report pulselessness. So the caprice of medical history reporting, the disease bears his name, but really quite inappropriate. So amaurosis definitely occurs in Takayasu's. And when you look at vascular features, tremendous overlap in findings. When you look at arterial involvement on the patients in whom we had imaging, that's 100% of Takayasu's and most of the patients with GCA, again, a tremendous overlap in findings. And again, this is not as good as Gorell-Osberg's study as having histology of the entire arterial tree, but it is hard to ignore these similarities between these. Now, we're not the only ones who have suggested that these are parts of the spectrum of the same disease. In fact, others have done so as well. And here's a series from Turkey where we're looking at 248 cases of Takayasu's. And among the characteristics that are reported, uncharacteristic headache in Takayasu's, almost half. Blurred vision, 21%. TIAs, 3%. Stroke, 15%. Musculoskeletal features, 42%, but they didn't break that out because they didn't ask the questions in the appropriate way as to how many of those would have been interpreted as PMR. And Arnaud, in yet another study from France, in a series of 82 patients with Takayasu's, makes the point that the data support at least an overlap between these two diseases. Now, so what am I suggesting? I'm suggesting that you can have the same disease at different ages and express that disease in a different way, even though you might call it by the same name. Well, is that really fanciful? Well, what if I, as a young person, got pneumococcal pneumonia? How would I be able to handle that compared to me getting it at my age or at 80 years of age? I think I don't have to convince you that the ultimate expression of a disease might be quite different based upon the age of the host. And we know this to be true in lupus, where the most severe disease, for example, occurs in young women of reproductive age, or in Henoch-Schönlein purpura, where it tends to be a benign disease in young people, but a more severe disease in older people. On and on with numerous examples. So these similarities, I think, argue for screening for large vessel vasculitis in all GCA patients, imaging the aorta and all branch vessels in GCA, and I think looking for similarities in etiology and pathogenesis in both of these diseases. We can't take care of these people independently as rheumatologists. We really need the help of a lot of people because they are complex. We need the help of imaging specialists. You need to know them by their first name. You need to get the studies when you need them. They should be your friends. Vascular medicine folks and cardiothoracic surgery, because not an insignificant number of these people are going to have large vessel surgeries. So with that, I think we can convene the panel and pick up on other questions. We actually have a lot of time. And we can start with questions directly to me for the last presentation and then have the group come up and you can fire away. Anybody?
Thank you for your talk. Technique to find abdominal aortic involvement. The question is just an atherosclerotic disease or is real aortitis? Do you have any guidelines how to differentiate between these two issues in that subset?
I think it's hard. So were you using as an example the abdominal aortic aneurysm?
Yes.
So abdominal aortic aneurysm is even harder because most abdominal aortic aneurysms are atheromatous. And the overwhelming majority, over 90% of abdominal aortic aneurysms are infrarenal atheromatous. And so even in those series where you have patients with GCA and an abdominal aortic aneurysm, most of the time they're going to be atheromatous and not GCA. On the other hand, if you're looking at a thoracic aortic aneurysm, the most common cause of that are matrix disorders, cystic medial degeneration. We know cystic medial degeneration well from Marfan's, and we know collagen disorders well from Ehlers-Danlos. But most of the matrix disorders that exist in large vessel disease are uncharacterized. So if you have a patient with GCA and their aneurysm becomes apparent at the point where they have GCA, and it is thoracic aortic, I think most of the time you're going to be compelled to think that that really is part of their disease, and you're going to be treating it. And if it gets large, because you already have important structural abnormalities within the wall, and it continues to enlarge even on treatment, which doesn't necessarily mean that it's active, could be, but it may just mean that that wall is already so compromised, it's going to get larger and larger no matter how well you control the disease. Then you're going to get a chance to look at that histologically. Hopefully, it'll be bland because you've controlled the lesion. So that doesn't answer your question in part because it's not easily answerable. It's a very hard distinction to make.
So what is the imaging modality you use? You prefer like a CT angio or MRI? Because it's difficult to get paid from the insurance company. If the patient has no abdominal pain, they don't let me do an angio just to screen for these conditions. So what do you do? Do you do CT angio of the chest and abdomen, or do an MRA of the chest and abdomen?
Well, I think which is the better test is still unclear, whether it's CTA or MR. I like MR because there's no high-dose ionizing radiation with normal renal function. There's little to no risk, and it's very nice for evaluating wall thickness. In atheromatous disease, you can also get wall thickness, but it tends to be patchy and raggedy looking as opposed to smooth wall thickening, which would be more characteristic of inflammatory vascular disease. That wasn't an easy question. You have an easier one? I had some questions I wrote down here, so I needed to get those.
Does this work?
I needed to pick your brains.
Anybody? Yeah.
Question.
I have a question, Dr. Hoffman. In terms of complex
infliximab, patients who are taking infliximab on Takayasu, are you able to wean them off, or are they on
I'm sorry, I think your question was on infliximab and Takayasu?
Yeah.
So I've tried to wean patients off infliximab with Takayasu, and my experience is not enormous because it's a rare disease, and even for me, I just don't have enough patients to report those tried to wean off versus those not. But most of the patients I've tried to wean off have had to go back on, with the exception of one person. So I can't give you great metrics on that, but I have not been successful. And I do try and wean it because some of our patients that we've treated with infliximab have improved, say, with 3 milligrams per kilogram. And then, they improved, but you couldn't taper them off their steroids. Now you're up to 5 milligrams per kilogram. Now you're down to every 6 weeks. And in our most difficult to treat patients where we had some signal of improvement, but we weren't at our goal, we have gone up to 10 milligrams per kilogram every 4 weeks and have then gotten good control of disease. So knowing that every patient's different, I have tried, when we have withdrawn, to slowly taper, thinking that there's going to be a breakthrough point here unless this disease has totally changed its characteristics, which I usually doubt has happened. So I slowly taper and look for a slight abnormality rather than a major event.
Gary,
I would
could I
just add-
ask a follow-up question? So if you make the diagnosis on Monday of Takayasu's in a 20-year-old woman, how soon will you go to a biologic therapy like infliximab? Do you put her on 60 milligrams of prednisone and keep her on that taper it off over 6 months? How soon do you go to a biologic?
So John's question really gets to a very important aspect of the heterogeneity of these patients. They're in some ways very similar, but in many ways very, very different. About 20% of people will actually have a monophasic disease, and either on their own, even without treatment, will come to you because somebody's picked up pulse deficits or bruits. And you evaluate them and you say, I'm sure this is Takayasu's, but I can't find anything that really points to active disease. So I think they took a hit. I think they responded in their unique immunologic way. And now they have these lesions, but somehow they immunologically corrected. And they had a monophasic disease, and I don't treat them. So we have seen those people in 20% of the NIH cohort and less than 10% of the Cleveland Clinic cohort. So they exist, and that's why John's question is so important. I think everybody deserves a chance to prove whether or not they have a monophasic disease, can get off steroids. If they don't get off steroids as you're tapering and they clearly have features of relapse, which are not so easy to read, then I usually will go to methotrexate and see if I can then taper them further. If I can get someone down to 5, 6, 7 milligrams of prednisone a day and get good disease control, I feel that's a reasonable compromise given how difficult it is to treat the disease and how little we know about it. If I can't reach that goal, then I'll add infliximab.